Our broadcast. There we go.
Okay, 23, 26, 27, 33, 38, 41.
So good morning, everybody. We're just giving it a few minutes and we're going to get started. Hi, good morning, everyone. If you are just logging on, just wanted to say good morning, and we're going to give it probably maybe till 5, 6 after. We'll see how many people we have logged in. Good morning, everyone. If you're just logging in now, we're going to give it probably till about 5 after to let everybody log in, and then we're going to get started.
Hope everybody's got their coffee or whatever time zone you're in.
Question and answers up. Good morning, everyone. If you're just logging in, we're going to give it till about 5 after, which I don't even know when is because I don't have a clock on.
10:01.
Thank you. I'll let you guys let me know.
1 minute after in our time zone.
Thank you. Good morning, everyone. If you're just logging in, we're going to give it till about 5 after, and then we're going to get started this morning. Dr. Vu, good morning. I'm looking it through the list. Oh, my father, Dr. Arthur Solomon, good morning. Dr. Twist.
Yeah.
Good morning, everyone. We're going to give it just a few more minutes and then we're going to get started. Dr. Bass Allen, good morning. Just going through my list to see who I recognize. Good morning, everyone. We've got chat up. Good. Good morning, everyone. We're still going to give it a few minutes before we get started here. We've got the numbers are rising. Kelsey, good morning. Just want to say good morning again to everybody that is logging in. We're going to give it a few more minutes. Let's see, Dr. Konings, what time is it?
10:04 here in the Pacific time zone. I'd give it 1 minute. 10:05 sounds fine.
Simon, good morning. Thank you for the message. Good morning, everyone. We're going to get started here in just a few minutes. We're going to let some more, oh, from Costa Rica. I knew we were international. Bienvenidos. All right. We're at about 2/3, so I think we're just going to give it a few more minutes, maybe 2 minutes, and then we'll get rolling this morning. Just going through my list to see. Oh, Dr. Chow, good morning. All right. Good morning, everyone. We're going to give it maybe 2 more minutes, and then we're going to get rolling our probably about 2/3, I think, of our signups right now. What's our time there, Dr. Coatings?
We are at 10:06 and a half.
Okay. Leave it up to the PhD scientists to give you exact numbers. Oh, we've got Argentina this morning. Wow, we're in Spanish. Perfecto. Bienvenidos. How long is the webinar? We're going to go about 2 hours.
Maybe a little less. We'll see. Not more than 2 hours.
Not more than 2 hours. And we won't be offended if people need to leave early. We know it. You're at home and you have kids and everything else. Should we go ahead and,
I think so. Yep.
Let's give it 1 more minute.
Okay. You're the boss.
Thank you. Good morning, everyone. If you're just logging in now, we're going to give it just a little bit here. We're at probably about 2/3 of the signups. Okay, I think we will there be a recording available? We're working on that. I believe the answer is yes. I'm not sure where it's going to be posted yet. All this is kind of new for us with Zoom. But yes, I'm going to try to post this after we're done. There's no CE, I'm sorry, Dr. Azar, this morning. There's just no way logistically of everybody's at home and trying to get out CE certs to 600 people worldwide. Okay, so I think we're going to go ahead and get started this morning. Good morning, everyone. I wanted to just thank you sincerely from the bottom of my heart for being here today. My name is Joshua Solomon. I'll introduce myself formally here in a little bit. But I just wanted to thank you for taking the time to being with us today. You know, years ago when I started with Bioclear and I started training, I had this goal in mind, and really from the first class was I wanted to spread this message and show what's available to my fellow pediatric dentists. And here we are, 3 years later, and we're here with that. And so I know this pandemic's been horrible for everyone around the world, but there has been some silver linings, and I really consider this one of our silver linings today to be with you guys. So I think we're going to go ahead and we're going to get started. Okay, perfect. All right, so just a financial disclaimer before we do anything else this morning. I think it's always important if you're going to hear someone speak to know where they are financially involved with if they're talking about a technique or a set of materials. So for myself, I have no financial involvement with today at all. I am an instructor at the Bioclear Learning Center, so I do get paid when I go teach courses, but that's it. All the work that I've done for this presentation, for the presentation today, I have no financial involvement whatsoever. The last thing that we wanted to do at this time is try to sell things to people, and that is not the goal this morning. At the very end, if you're interested and this is something that you want to start integrating in your practice, you want to learn more, there'll be some information about classes, and that's up to you if you want to sign up for that or not. But it's just important to get out as we start this morning. So questions and answers. For all of you, we will do our best to answer as many questions as possible. If you haven't used Zoom before, there is a question and answer button. There's also a chat. So the chat is really more like texting back and forth. But if you have questions, Dr. Bustamante, I'll introduce him here in a minute, and he will be answering questions when possible. If there's a lot of questions, if you can't get to your question today, we'll keep a log of all the questions. We can also email you. There'll be lots of contact information for everyone. Okay, there's going to be a couple polls today. The polls are anonymous, so if you click your answer, no one's going to see that. There's only about 3 of them, so we would appreciate if you could, just respond to those polls. And then just another disclaimer, I am at home, and so if you hear dogs or the doorbell or children or wife or other things, I apologize ahead of time. I would have liked to do this in a big professional sound studio, but we got a pretty nice setup here at home. But you may hear some noise in the background, and if that happens, I am sorry. Okay, so what we're here to talk about today is the Bioclear Method. And as a pediatric dentist, when I started training with Bioclear 3 years ago, as I said, I had this goal after my very first class is to bring this to as many pediatric dentists as possible. And the reason for that is this is something I'm extremely passionate about. There's not anything that I do restoratively, almost anything, that doesn't involve at least some step of what I'm going to teach you guys today. Now, today is this is a kind of a high level course where we're just going to look down and you're going to see the basics of things. I don't expect anyone to be able to, go through this course today and then buy all the stuff to be able to do it right away. You may be able to do that with some technique cards and videos and some follow-up, but really today is just going to be an overview for you. So the Bioclear Learning Center is located in Tacoma, Washington. It's an international organization or international training center. So there's a training center in the UK, in Sweden, and then just recently in Europe, excuse me, in the Middle East, in Egypt. We'll also, we're going to be talking about some 3M composites today and composite burrs, and you'll see how all this works as a system. So this is the Learning Center faculty. Dr. David Clark is the founder of Bioclear. And if you know anything about Bioclear, if you've seen videos, you've seen him. He's very prolific. He's been on many magazines, many journals. And there I am down there. Just recently, I was asked to be adjunct faculty. So I was teaching some hands-on courses. And now I've asked to be a faculty member, and something I'm very proud of. And again, I'm extremely passionate about this. And I hope to share that with you this morning. And then we'll introduce Dr. Mark Konings here in just a minute, who's with us today from 3M. So the first person I want to introduce is Dr. Rafael Bustamante. He's one of our Canadian dentists, and he's been training with Bioclear for years. He is a veteran with a microscope, I think 16 years. He's been using a microscope. I'm very jealous. I want a microscope at my practice. And he really is an expert. And he's going to be with us today to help answer questions. I put his email address here, especially if you're in Canada. If you have questions, feel free to reach out to him. And then, Dr. Konings, did you want to introduce yourself this morning?
Yeah, hello everybody. My name is Mark. I'm with 3M Oral Care. I'm a doctor, but not a dentist. I have a PhD in chemistry. And as a 3M employee, I get paid by 3M. So there's my financial disclaimer. And I have no financial relationship or interest with Bioclear. You click to the next. I think there's a couple more. Degree in chemistry. I worked for 3M about 30 years now. I spent a lot of time in research and development. I was also in marketing, and I was the U.S. marketing manager for our pediatric line of products. So I did a lot of research projects around pediatric dentistry. I'm pretty familiar with pediatric dentistry. A lot of that was back in the early 2000s. So we'll see how much pediatric dentistry has changed. And then for 13 years, I was a 3M sales rep where I live up here in Seattle, Washington. And now I'm the global education manager for 3M. And basically what I do is teach Bioclear for 3M. And yep, I got a daughter, a wife. I like to go to some big sports events with my daughter, and we'll see when we can get back to one of those, go see music with my friends. I'm supposed to be in New Orleans right now for Jazz Fest, obviously not. And when I'm not doing those things, I try to get out hiking in the mountains or maybe snowboarding. And again, there is my contact information, my email information, my phone number. You can text me. And I also have a YouTube channel. My YouTube channel, it's just my name, Mark Konings. And I've lost count. There's about 800 Bioclear videos on my YouTube channel. And they all start Bioclear Method. And you can put in a search term, prepping, injection molding, all the different things you'll learn about today. If you want to learn specifics of a particular technique, you can find it on YouTube.
Okay, thank you. Oh, there you are again. All right, so just to introduce myself this morning. So I'm a second generation pediatric dentist. I took over the practices from my father, Dr. Arthur Solomon. So I went to dental school at UOP in San Francisco, and then I did my pedio residency at University of Texas, Houston, at the dental school there in the med center. And we're going to be presenting to them, I think, next week. Dr. Konings and I have already presented to several residency programs, and we have a few more coming up. So I got interested in oral biomaterials during my residency. I had the option of doing a master's thesis, and I took that opportunity to work with Dr. John Powers, who's a really well-published guy in oral biomaterials. And, from there, I learned how to use an Instrong. I learned how to thermocycle resins. I learned how to use the scanning electron microscope. And I really developed a passion for these things, and that's really what got me to here today. So I'm a diplomat of the board and a fellow. As far as the Learning Center, I mentioned that this morning that I'm adjunct faculty. And then about a year, I think and a half ago, I became a key opinion leader for 3M. So what that means is, I go out once or twice a year. We talk about these products. We talk about the Bioclear Method. We talk about how we can improve techniques, how we can improve education. And it's been something that's really fulfilling, and I'm very thankful to do so. I have two practices, one in Livermore, California, and one in Tracy, California. So it's probably, San Francisco, East Bay. And I'm connected to the Valley Care Stanford Medical Center. So got things kind of easy in my Livermore office. I'm right next to the surgery center there. I have several associates that work with me, Dr. Hazel Solomon, Dr. Stephen Coe, Dr. Joshua Twist. And I think they're on here this morning. And my contact information, I made a new email address here just so I could keep everybody, my regular email and Bioclear separate. So if you have any questions, please feel free to email me. That's my job. My job as an educator is to help everyone. If you want to talk about treatment planning, if you buy everything and you have questions, if you go to a course, you have questions afterwards. If you want to send me pre-op photos, post-op photos, that's really how I learned. I attached myself early on to Dr. Konings, whether he liked it or not. And, we went through everything with curing lights and talking about bonding and can you clear through a matrix. And I really picked his brain. I did the same thing with Dr. Bustamante. He was one of the hands-on instructors. And there are some really, really talented, top-notch people that are educators within Bioclear in photography, in material science and bonding, and we're here to help. That's really our job. So I want to tell you a little bit about my journey. So like many of you, or most of you, I was trained with GB Black Dentistry. I graduated UOP in 2001, and I don't think it was a long time ago, but I don't think I did many composites. We learned just regular GB Black Dentistry, and we're going to talk about, fortunately, that's how most people, I think, throughout the world are still practicing, even though we have these new materials. So I learned how to do amalgams, and amalgam's still a good material. Amalgam's used throughout the world. I mean, there are issues with pollution with it. And so in some countries, amalgam's been pulled, but in the States, they still teach the amalgam. They teach amalgam for the board. When I got to my pediatric residency, as all of you know, we're so busy with learning how to take care of children and pediatric medicine and anesthesia and sedation and all of those things, special needs patients, all those things that we're trained for. And unfortunately, we just don't have a lot of time to learn things besides the basics. And so what I was taught during my pediatric residency was, pretty much if you had caries on an E on a primary second molar, there was proximal caries that got an MO amalgam. If there was proximal caries on a D, a primary first molar, it got a stainless steel crown. Did a few resins, sealants, but really, once I got out of my residency in 2003, I was pretty much on my own. And when I got to private practice, I placed amalgam, I did stainless steel crowns, and I knew I wanted to do something different. Now, some of that was my preference, a lot of that was patient preference. So I have purchased, I think, every single matrix system that has been made. I have stuff in my cupboard from Russia that I had imported. I mean, I really have gone through every matrix system, every polishing system, burrs, composites. I do not think there's a product out there that I haven't tried. And for years, I struggled because I thought the problem was me. I thought that I didn't have good enough hands. I didn't think, I could contour my matrix properly. I thought that, my dentistry should look better, right? And I've come to find out that it really was not the tools, not the training that I was given. Well, some of the training, but a lot of it was the tools as well. And so I've been on this search ever since to improve my dentistry. My goal is I'd like every single one of my x-rays and every single one of my restorations to be at the point where I can publish it, or I can show a parent, I can show a colleague, and be proud of that. And just for years, I felt like that wasn't where I was at. So when I transitioned to using posterior composites, I was using sectional matrices and wedges. I got pretty good at using these. I've taught hundreds of dentists on courses how to use metal sectional matrices. But the problem is, at least for me, is a matter of being consistent, right? Do my restorations look like natural contacts? Can my patients keep those areas clean? Are these restorations fracturing over time? Do we have recurrent decay? Did I get all the decay out? Did I properly clean the teeth? And, the problem, as pediatric dentists, as is often, we may be seeing 30, 40, 50 patients a day. And when we do procedure, we need to do it precisely. And we don't have a lot of time in the chair. Often, if you have, a difficult 3 or 4-year-old, unlike, for our general dentist colleagues, we don't have an hour to sit in the chair and restore one proximal restoration. And that's really what got me here today. We've had, let me go back once. We've had a little bit of this aesthetic increase in pediatric dentistry with the zirconia crowns. I do place those. And really what I think has happened, especially in the last couple of years, is there has been a push for more aesthetic restorations, but there hasn't been training for that. And that's what we're going to show you guys today. And I said here, I still haven't found what I was looking for. So I got to this point after, 10, 12, 13 years where I just wanted to do things differently. And I knew that I needed to take my work to the next level. So like many of us, I became a YouTube dentist and had a minor in YouTube. And I would spend hours a day when I had time, looking on YouTube, looking for people out there with techniques or with occlusion, and I just wanted things to be better. And then, I'd say 3.5 years ago, I found Dr. Clark with Bioclear, And I probably watched videos, I don't know, for 3-4 months and finally said, you know what, this is worth my while. I'm going to go out. And then from there, I've taken I think every single class plus that's offered at the Learning Center. You don't need to do all of this. I really wanted to learn everything and hopefully become an expert at the end of this. And so I've been through all of these courses, and we'll talk about a little bit later, if it's something you're interested in. There's lots of ways to learn more. There's hands-on courses, but this is what got me here today. So the Learning Center is in Tacoma, Washington, beautiful facility. It's connected to Dr. Clark's office. So his office has, I think, at least 12, 13 microscopes there. So pretty much every single chair in the clinic has a microscope. If you haven't used a microscope before, it really can show you just minute detail and just overall improve your understanding of how things work on a microscopic level. This is the Learning Center here, very small class size. So I think the max is 13 to 1 or so, 13 to 2 or 3. So very small, hands-on. We put you through a few days really of 8 to 10 hours a day of really intense restorative dentistry, and we're going to talk about those things today. So I got to this point, I mentioned my challenges with direct resin composite, and I don't think I'm any different than any of you that are with us today. These are not easy procedures to do unless you've had training, unless you have the right materials. And this is the same problems I think that all of us have. We were taught, most of us, with a flat piece of Mylar. And how do you expect me to get an emergence profile? How do you expect me to get a marginal seal? How do you expect me to be able to blend these restorations if I have a simple flat piece of Mylar? And often this is what we see, right? These overhangs, we see voids that are composites, we see staining. This is actually my Sophia, who's 14 now. Very, very small laterals, two-size discrepancy. How do I take this little piece of flat Mylar or try to hand sculpt these teeth to make them actually look like teeth? And I've been through many CE courses where we talked about layering, 3, 4, 5 different shades of composite and adding, spectral highlights and adding, adding dye throughout the tooth. And the problem is number one, these restorations would take, maybe 2 hours. There's just no way as a pediatric dentist with a busy practice, you have the time to sit there and try to use complex layering to restore these teeth. And the problem is a lot of those teeth that I did restore, they wind up fracturing. In the posterior, I find that the problems sometimes get worse. And this is what we often see with, I would probably say, a vast majority of dentists that are placing posterior composites. We get these kissing contacts, right, where we have a contact at the incisal edge, the incisal third of the contact, and every time that patient bites, what happens to the forces on those teeth? Every time they eat, food's getting stuck in there. And the problem is with a flat piece of Mylar or with a Toffelmeyer or with a preformed metal matrix, often these are the contacts that we get. We see recurrent decay, we see staining at margins. Unfortunately, with sealants, we see that sealants just don't last for some patients, even in the hands of a very good practitioner, where we get cuspal failures, we get sensitivity. We're going to talk about why all this happened. For years, I didn't know why this happened. And we're going to show you that today. So speaking of, having issues with composites, I love these couple photos because, what this shows is this composite was only 3 years old, right? This whole cusp fractured. But what happened here? This amalgam was probably in here for 20 years. It did just fine. Why did this cusp break? For us in pediatric dentistry, if you practice long enough, you're going to see this. Residents, you're going to see this. And I thought when I had a restoration fail like this in a tooth fracture, that it was an issue with bond strength of my resin, or that, I may have, not placed my layer, the occlusal layer or my cuspal layer properly. And it turns out this is an engineering problem. This isn't an issue with the resin. This isn't an issue with the bonding. This is an issue with engineering. And we're going to show you why. Okay. So we talked about GV black, and a majority of dentists now, I would guess, that are still prepping teeth like this, right? If we look at these photos, remember this is from the 1800s. This was before the telephone, And this is how, honestly, most dental schools, I think, at least in the United States, most of them are still teaching preparations. And if these look familiar, this is what most dentists do. And we're at a point where we have these new materials and material science, these beautiful composites that flow beautifully on the teeth, have thixotropic flow, but we're still preparing these teeth like we did in the 1800s. So this is one of the most important slides today. This is going to be part of the home participation. So what I'd love everybody to do is take your hands, you're gonna put our hands like this, or put your hands like this. So this is an example of a compression joint. We're going to talk about basic engineering principles this morning, and this is the most important concept that we're going to talk about. So this is compression. Teeth restorations, this is how they want to live. When we think about why is it that a sealant, we can place a sealant on a tooth, and that sealant can last years and years and years, but we can then secondarily place a small occlusal composite and it fractures or it redecays. The reason being is because of the forces that are distributed throughout that tooth. This is compression. The opposite of that is tension. Teeth do not like to be in tension. When we look at the GB back preps, that's a mortise and tension joint, right? So we have parallel walls, we have a brittle material, and every time that tooth thermocycles, every time we have a cuspal load, we are sending those forces directly parallel into the walls of those restorations, and this is where we get failures. Once I had someone explain to me that why is it that these sealants last for so long and there's no bonding agent, why is it that they last this long in the teeth? And that's exactly why. It's the forces that are acted upon those teeth. As that child or teenager bites, those occlusal forces are directed parallel to that occlusal plane, and the forces are spread throughout the tooth. It's the same thing with porcelain veneers. Porcelain veneers, can last a very, very long time. Why is that? We're bonding to enamel and we are in compression. Just a quick example of the first Bioclear restoration that we're going to show. This is, if I can have all of my posterior teeth look like this is what I want. So this patient had enamel hypoplasia. You can see that there's temporary filling here in the back. First molar was the same thing. This is heated injection molded composite. This is a calla lily preparation. Calla lily is the flower we look from. We're prepping the tooth where we're rounding from inside out. We're spreading those forces laterally across the tooth. And the finish and polish on this tooth looks and feels like porcelain even a year later after I placed it. So this is the armamentarium that most pediatric dentists, at least in my experience, are using to place posterior composites. These are preformed metal matrices, and no wonder why we have these contacts. There's no way that a stiff preformed metal matrix can reproduce biomimetically what that contact is supposed to look like. My goal really should be is that I want my restoration to look like a tooth. I want my patients to be able to floss in this area. I want my patients to not have fractures because I don't have an embrasure space that is cleansable. And these are fine for amalgam. Most people, when they place amalgams, they're using these or using just metal strips. But a composite is not going to work in these restorations. Again, in permanent teeth, it's the same thing. And once in a while, if you're good with a metal matrix, I find you can get a decent contact in the middle third of the tooth, but it's just not consistent. And we have the same problems in primary teeth as we do in permanent teeth. So this is sonic fill, decent material. I've used it in the past. But again, this is only at 4 years. Why did this restoration fail? This is a GB black prep, walls that are 90 degrees, parallel to each other, occlusal forces. Every time that patient bites, we see what happens as those cusps get pulled apart, that tooth flexes, and then our restoration delaminates from the teeth. As a pediatric dentist, unfortunately, we see this all the time. This patient referred to me, they kind of did half of a pulp. Probably a flat metal matrix to restore this tooth. They didn't prep enough enamel or dentin away. And unfortunately, you can see these restorations, I think, were placed a year prior to when the patient saw me. And we can do better. MO composite. So this is slot prep. Some of us are placing slot preps and really, I think it's to save tooth structure. And this is only a year later with this tooth debonded. This is one of my favorite slides, right? So it looks like the tooth is crying. This is a flat metal matrix, right? And they tried, they have a fairly broad contact here, but there's no way patient can floss. And of course, huge overhang here. Sealants, this patient was referred to me, I think it was last year, and they just had sealants placed. Well, they had sealants placed originally, and then they had sealants, the teeth were resealed about a year later. And we can see there's this little tiny mound of sealant here, but all that sealant has debonded, and there's recurrent decay in all of these grooves. So we talked about the problem. So let's now talk about the solution. And so, with the state of material science now and technology, we have cone beam, and we are detecting caries with lasers. We have digital X-ray, but now really I feel like it's a time where we need to make a change. Our materials have caught up, but not our armamentarium, not our ways of placing those into the teeth. And this is what I want to see for my restorations. Now, this is a 10-year post-op. You look at broad contact, no recurrent decay. Yes, these teeth could be polished a little bit, but at 10 years, if every single one of my restorations looked like this at 10 years, I would be very happy. Same thing, this is a black triangle closure. I know in pediatrics, we don't do this very often, but we do place a lot of class 4 and class 3 restoration. 6 years, you can see no voids in these teeth whatsoever. So what is Bioclear? So now we're really going to get into the detail today of what I want to show you. So Bioclear was founded in 2007 by Dr. David Clark. Many of you have probably seen videos and articles with him before. And the whole point of Bioclear is to take these GV block preparations and take dentistry the way that we were doing it since the 1800s and bring it into today. You're going to hear some new terminology. We're going to talk about heating composite. We're going to talk about injection molding composite. We're going to talk about how to polish. We're going to talk about, instead of matrices, really anatomic tooth forms. We're going to place a matrix in a tooth that actually looks like a tooth. And within a couple years ago, 3M partnered with Bioclear to provide millions of dollars of research behind all these methods and materials. We're going to show you some research today because it's really high-level presentation and we don't have a lot of time. We're not going to get into a lot of studies. I'm going to show you some, but if it's something that you're interested in, please email me and I can follow up and send you studies. So we're going to talk about the 5 really pillars of Bioclear. And the first is, there we go, biofilm removal. We're going to talk about how do we properly remove that sticky proteoglycan covering and Cheetos and gummy bears and everything else that's on our patient's teeth. Secondarily, our preparation design. There's a whole new preparation, and these are non-retentive class 2 preparations that are caries specific and maximize the amount of enamel that we're bonding to. We're going to minimize the amount of dentin that we expose, and we're going to decrease the amount of sensitivity we have in the teeth, and we're going to spread those occlusal and lateral forces throughout the tooth. Then our matrices. So this is a new design of a ring that you likely have not seen before. I mentioned our matrices. So these are really anatomic tooth forms. With a metal matrix, they're not shaped like a tooth. We have to push and burnish and adapt that metal matrix to the tooth, where this is actually the shape of the tooth itself. And then the diamond wedges. We're going to be heating and injection molding composite. The first time I heard that we were going to be heating composite, I thought it was going to maybe catch on fire. I thought it was going to cure right away. But we're going to show you that you can heat composite. We can increase the thixotropic flow, and we can spread those restorations, inject them into the teeth with ease because of heating these materials. And then lastly, the polish. I've been through every single polishing system, every single polishing cups, pastes, and I'll show you a very quick and efficient way to get porcelain-like shine on all your restorations. So the first component here we're going to talk about is removal of biofilm. And this, what I wanted to show you is an example of, at the very beginning of what our Bioclear restorations look like. The reason why that we need to properly clean the teeth is because our restorations in the posterior, the restoration probably ends somewhere here on the midfacial and on the midlingual. And instead of using extension for prevention, instead of having amalgam GV block preparation and tracing all the grooves of the teeth, we're going to be extending our restorations past the quote unquote margin here proximally and somewhere on the facial and somewhere on the lingual to increase the amount of retention and to spread those forces throughout the tooth. For years, I didn't have a really good idea of why I was getting recurrent decay or staining in our margins, but what never made sense to me are why are we placing these restorations back in the exact same place where the caries were? And again, if we're able to properly clean the tooth, we can now, instead of have a margin, we can have a tooth restoration interface and end that composite somewhere here on the midfacial or midlingual. I'm sorry, I'm going to go back. Actually, I'm just going to continue showing you some Bioclear restorations. Got ahead of myself. It's very easy for me to cherry pick and show you restorations that I've done in the last 6 months, but I didn't want to do that this morning. What I wanted to show you were restorations that I placed literally coming right out of the Learning Center. So this was the first proximal composite that I placed, this tooth number 3. You know, I was worried the first time after leaving the Learning Center, but these are my results. My polish now is usually a little bit better, but if I can actually still get this result today on every single one of my posterior teeth, I'm going to be very happy. We see we have a nice broad contact. That contact is in the middle third of the tooth. We have proper embrasures. This is additive dentistry, so this tooth is slightly bigger now, but that is going to spread those forces laterally throughout the tooth and keep this restoration in this patient's mouth for a very long time. My second restoration that I placed, same exact thing, number 3 MO. You can see with some transillumination, the caries there in the mesials, probably a little bit of a fracture as well. And that was the final result. This slide was, I think it's a really good example of showing the differences of what these restorations look like on the x-ray. So this was, I believe, a 13-year-old patient that was referred to me, special needs, but fairly cooperative. We can see he's had a bunch of composites here placed in the bottom. They looked okay. I got a little bit of snagging floss. Clinically, they looked all right. I wasn't planning on, changing any of these restorations out. But what I wanted to do here is to place, use a metal matrix on one side and then a Bioclear Biofit matrix on the other. And what we can see here is, again, that margin slightly past, the composite slightly past our margin, nice embrasure. And with metal matrices, although I got a good result here, I can't get this result every single time, but I can with my Bioclear restorations. This is a good example of my progression over the years. So this was a patient that I treated, hypoplastic molar. I look at this now, I'm really not happy with this restoration. It was starting to delaminate. We had a little bit of recurrent decay. And this is my Bioclear restoration. So MOB composite actually. And we can see, so I've covered a few of these cusps. This restoration is smooth. And I know this is gonna last many more years than the restorations I placed before. It's a beautiful case. Dr. Regalado, who's one of the faculty members at Bioclear, this was tooth number 20DO, composite, had some recurrent decay, starting to delaminate. And if we go through the slides, so this is after composite or the restoration was removed. This is cleaned and blasted, and this is the final result. Absolutely beautiful biomimetic contact. This tooth is now in compression. We know it's going to last a very long time. Again, another example of what our contact should look like afterwards. This polish and the occlusion is this tooth should stay for a very long time. And again, right now these restorations take me probably, I would say almost the exact same amount of time, if not less, because when we're using a matrix that is actually shaped like the tooth, I don't spend a lot of time afterwards having to finish, having to polish to be able to get these type of margins. I wish this case was documented a little bit better. This looks like a Ninja Turtle. This is a patient, special needs, and you can see how hypoplastic this tooth was. Really circumferentially around the tooth, very little enamel, very little dentin. These aren't the greatest photos, but you can see what a monolithic composite looks like. This is one bulk cured composite using Filtech 1, and this is basically a composite crown around the tooth. Beautiful case of selective caries removal. It's something that we teach, where the 3 rules are: don't expose the pulp, don't expose the pulp, don't expose the pulp. In the past, I would have most likely removed all the decay, possibly sent this patient to endo, stainless steel crown, and I can't tell you the last time that I've actually placed a stainless steel crown on a permanent molar. So selective caries removal, the dentin, the DEJ, all the caries were removed. And we just use the blaster here to clean the top of the tooth. And this is our final result. I show this picture down here because it reminds me of, this was a tooth a series that I sent into Dr. Clark, and I was really proud of my work. And the thing that I did not realize is this tooth is not going to last long. And the reason being, I only have probably 1 millimeter of composite over my dentin. And this is an example of, as a dentist, we're trying to make things look aesthetic, but I just completely forgot about basic engineering principles. And so my restorations for posterior for large occlusals or occlusal buckles, they're going to look like this. And I try not, don't expose the pulp. If this is a symptomatic tooth, that's a little different story. But with asymptomatic tooth, this is caries. Caries removal just short of the pulp. Selective caries removal. Thank you. This beautiful case by Dr. Bustamante, our own Dr. Bustamante there, tooth number L, using Bioclear wedge and ring, and absolutely beautiful results afterwards. This is my Sophia. I showed her picture at the very beginning. This was actually my 2 first laterals that I did coming out of the course. Now, I would do things a little differently today, actually. It's the first time my assistant was helping me, and we mixed posterior composite and anterior composite. But this was coming, right out of the class. And before this, I'd really done very little anterior composite work. This was a case with actually my electrician. He walked in one day, he had to rewire one of our sterilizers, and had his hand over his mouth. I knew he was embarrassed. I knew these teeth were hurting him. And he didn't want to say anything, but I think he kind of knew he wanted me to take a look. So we got him in the chair during lunch. And before before Bioclear, this was my only way of restoring these teeth. Was I either have to do this by hand or I had a flat piece of mylar. Again, things are different now. So we're not gonna focus a lot on anterior teeth today, but this is an A101 HD matrix in the anterior. And this was my final result in about an hour, I believe, hour and a half or so. And one of the beautiful things we could see with this 3M composite, this Filtech Supreme Ultra, is that this is one shade of composite, and we're actually able to change the color based on and increase that polychromaticity of the resin itself by thickening or thinning that resin. So here at the cervical area, my restoration is definitely thicker, and as I thin, we can see the color change throughout the tooth. Another fractured incisor, for all of us that are pediatric dentists, we see these almost on a daily basis. And these can be very difficult restorations to place and try to hide, the line that we often see. And again, this tooth was restored with just one body shade. That's it. I believe this was WB. Depending on the shade of the patient, there's probably only 2 to 3 anterior shades that I use. And you can see our final result. This was one of my first kind of full mouth cases. Well, actually, just the 4 anterior teeth. I don't think I did the canines. Finished ortho. This young man had very long rectangular teeth. You can see tooth size discrepancy there. And again, that is, go back. Not wanting to go back. That's okay. We're going to go ahead. So just one or 2 more cases here. Peg lateral, something we see all the time. And I used to just refer these patients out to pros. I didn't restore any of these teeth myself. And parents, most of the time they want us, we've established that relationship with that child. They want us treating these children. So this preoperative, and this is immediate postoperative. So again, this is one shade of composite that is injection molded. And really the thing I want to show here is the follow-up. So this is Dr. Clark's case. This is 3 years, 5 years, 8 years, 10 years. Yes, we have a little bit of staining at the margins, but if you look, that restoration, the finish and the polish on this tooth looks almost the same as it did the day that it was placed. Okay, let's go back one. Sorry guys, I'm having a hard time going back. There we go. Okay. So this is a Venn diagram of the way that we've been taught to place amalgam. And the reason why that, if you look at most dentists, that they're able to place amalgam efficiently and that the end result really looks the same for most of us is because there's a prescriptive method of placing amalgam. If you go across most dental schools in the country or internationally, the way they're teaching to place posterior amalgams are likely the same for everyone. And so what happens is if we have a prescriptive method of placing these restorations, GV black preps, the amalgam, Toffelmeyer, and we condense an amalgam, we're going to get the same result. So then in the 60s, way before my time, 3M came out with the first white material. And the problem was this was a horrible replacement for amalgam. It heated, the restoration, it shrunk away from margins. We had problems with thermal cycling of the teeth and sensitivity. But the issue is we didn't change anything else. And really, this is where we're at today is, I call this kind of the Wild West of posterior composites. And this is why so many of us have issues because there's not a prescriptive way to place posterior composites. If you look at most dental schools, they're likely teaching, different preparations, different matrices, in private practice, are we layering, are we snow plowing, are we putting in GI? What type of matrices are we using? Are we using the Toffelmeyer? And there's really not a prescriptive way of placing these restorations. And this is why we have so many problems. So in 2012, we now have, Dr. Clark came out with a way of prescriptive method of placing these restorations. And what we have is a tooth, we have a matrix that is the actual shape of the tooth. We talked about blasting, where we have composites that allow to bulk fill, and we have a new preparation design. And this is the way we're going to standardize and really increase our proficiency in these restorations and be able to place restorations that we're happy about, every single time. So the very first part of this process is removing the biofilm. And we're going to talk about the rest of these steps here in just a minute. So with biofilm removal, it's just like if you were going to, paint your deck, you're going to restain your deck, you've got to properly clean this. If you don't learn anything else today, this is one concept that I really want you to take home, is to please use disclosing solution before you're going to place a restoration. Before you place that sealant, before you place that occlusal restoration, your anterior restoration, is to please put disclosing agent on here. Caries detector is something completely different. That's just going to detect caries, of course, as the name shows us. But let's see why we use this. So these anterior teeth, rubber dam was placed, and they were scaled and they were pumice, and then we used disclosing solution. And we see what's left behind here. And this now makes sense to me after I saw this of why was I getting some staining around margins of my class 3 restoration of the anterior. The problem is it wasn't clean. These have been blasted. Now we've got enamel that we can properly bond to this whole surface. I would urge everyone, when we get back to practice, is to do this little experiment for yourself. So this patient was going to get an occlusal composite and a sealant here, and I went through with a bristle brush and I cleaned these grooves as much as I could. I really laid on this. I spent a couple minutes cleaning these teeth off, and this is what was left behind. This tooth, if we didn't clean these off with a bristle brush, this is what's going to be left behind. And we see why we have leakage around sealants. We see why we have sealants that just don't stay on the teeth. Again, in case of primary teeth, how many times do all of us prepare, doing proximal restorations here? We go ahead and remove caries, we do a preparation. And what I wanted to show here is how much biofilm is left. And these teeth would have just had matrices, and we would have placed our restorations, and away we go. We would have left all of this biofilm behind. So biofilm itself, we know, is that sticky proteoglycan layer of that's left behind by the bacteria in our mouth, or it's Cheetos, or it's gummy bears, all those things that that our patients have on their teeth. This is the blaster that we're going to use. So that it uses the powder's aluminum trihydroxide. So it's the same new hardness about as dentin. So you're not going to cut enamel with this. If you have air abrasion, it's very different, right? Air abrasion, I use that in my practice. We're able to actually cut enamel and dentin with that. If you lay on this hard enough, you probably can remove some dentin. But what I want to show you here is how the blaster works, and that phosphoric acid does not remove biofilm off the teeth. So rubber dams in place, we're going to go ahead and place our disclosing solution, and then we're going to go back through and place our etch for 20 seconds. This is sped up a little bit. We're going to dry, and we can see all of that biofilm that was left behind. And we see that biofilm is not removed by acid. So this is the blaster, and the blaster is a mix of water and these aluminum trihydroxide particles. It only takes about 2 minutes or so, per tooth, sometimes a little bit less. And then we remove biofilm off the teeth. Let's go to our next slide. Okay. So the preparation design is one of my favorite things to talk about because this is really going to be completely new. And what we describe these restorations is ice. So this is an infinity edge. This is compression-based preparation, and it's enamel-driven. When we place amalgam in teeth, we think of it as putting just a plug in the top of the jug. We are just filling that hole again, whereas we place these restorations, we are wrapping that entire restoration mid-buccal to mid-lingual in composite. We're spreading those forces laterally on the tooth. We're placing the quote-unquote margins of these restorations in cleansable areas. We talked about compression and tension, right, with our mortise and tenon joints of our amalgam restorations. We were getting fractures, these teeth, we get cuspal failures, but now we're going to spread those forces laterally on the teeth. Why do we have to do this? Why is it that composite's different and causing these failures in teeth? And the reason is composite we can really think about as almost like diamond. So a diamond is very brittle, right? But it's hard. You can take a diamond and you can cut with a diamond, but you can also take a raw diamond and cleave that diamond, right, to shape it. And so if we look at, these are all major brands of composites, we look at the difference between that compressive strength and then the tensile strength in the teeth. And we see that it's 4 to 5 times as strong, putting these restorations in compression. So how do we do that? I want to do a little poll here. So let's go to our poll. And actually, let me show you this, and then we'll do the poll here. So we know what a GV black prep looks like, parallel walls, extension prevention across the occlusal. And as I said, most of us in dental school, and even I think in today internationally, are still preparing teeth like this. Then came along the slot prep, and the slot prep, I think, was designed really to minimize the amount of tooth structure that we were removing. But the problem is, if we look at our C factor, it still is high. We have all these parallel walls, and I've seen many slot preps in primary and permanent teeth, and honestly, I've seen most of those restorations fail. And then here we are today with the Clark Class 2 preparation. So I wanted to do a quick poll here, and just to see, there we go. So if you can just go ahead and respond, I wanted to see the difference how people are preparing their teeth now. We're using GB black preps. Slot prep, how many of you are utilizing the Clark Class 2 or then some other, prep design that you use? We'll give this just a minute. And this is really the numbers that we expect to see. And when we ask this question, this is typically about where we're at. And a majority of dentists are still using GB black preparations. I see some of you, there's some of you that may be using Bioclear now. So most of us are in this kind of, GB black and slot prep world. So what is the Clark Class 2 preparation? I'm going to skip that slide. So bevels are bad, boxes are bad, bevels make them less bad. The Clark Class 2 preparation replaces beveling with radius walls. So if we look at this preparation, I'm going to show you a diagram, and then we collected quite a few photos of actual teeth to show you what these restorations look like in the mouth. But there's some key aspects of these preparations. So the first thing is we need to remove biofilm. We talked about that. We're using that blaster to properly clean this surface. We have all internal line angles. There are no stress rises or sharp angles in these preparations whatsoever. Again, these are non-retentive Class 2 preparations. So I'm not using parallel walls to be able to hold that amalgam in place, to pack that amalgam in place. We know that composite doesn't pack. And by spreading those forces throughout the tooth, we don't have to worry about using a preparation design that is actually going to we're going to pack the restoration into place. And in our affinity margins, as we blast this tooth and we place our restoration, we wrap this around, what we're going to see here in a few minutes is that our matrix actually will cover mid-facial almost to mid-lingual, and we don't have a margin anymore. Composite does not like to be marginated, and our actual restoration here is, these are just a picture of, in general, kind of where our composite is going to flow. We're actually past the quote margin here on the proximal area and the buccal and the lingual. When we place these, when we prepare these teeth, our C factor sometimes is actually less than 1, whereas in a amalgam GV black preparation, that C factor can be 3 or 4. I'll show you here in detail in just a minute, but Comet burrs, I switched to Comet probably about a year ago and I haven't looked back. I was having a problem with replacing my diamond burrs all the time, and we have now a prescriptive way of preparing these teeth. This is a burr block that's designed just for Bioclear, and these are burrs that I use on a daily basis. Another thing I wanted to show is this is just a representation of what happens when we cure composite and the polymerization shrinkage. We can see if we try to put that composite in a box, the areas are red, are a much higher amount of polymerization and shrinkage, and this is how we have pain and sensitivity afterwards. As we're curing these restorations, those cusps actually get pulled towards the center. Whereas if we use an infinity edge and wrap the composite completely around the tooth, we can see what happens with those forces. They're spread laterally all throughout the tooth. So this is a representation computer model of forces. We're going to use basically a ball here, and we're going to press on top of this molar that's had GB black preparation and an amalgam. And as we load this tooth, you can see where we're starting to get forces built up, both on the inclined planes of the cusp and then internally. And how many of us have seen where we have fractures that go down from the margin of our restoration throughout the tooth. And this is what we saw. We saw after enough occlusal load, the cusp split and we were fractured right through the occlusal plane. So this is a standard GB black preparation. Here, this is a calorie preparation. So we started with a GB black preparation, and then we rounded the margins here. So we're going from thin to thick, and we're going to spread these forces laterally on the tooth. And what we see as we progressively load this tooth, 7 to 8 times less force throughout that tooth. And where does this actual restoration break? This is eventually going to break intraresin on this computer model. And I've actually never seen that. I'm sure that can happen. But this is how much force it takes to actually break that restoration within the restoration itself. Let's go forward here. Okay. So this is an example of a GV black preparation that we're all familiar with, and a Clark class 1 preparation. This is the calla lily design that we talked about. So typically what I'll do in order to shape this tooth is I'll use that Comet Christmas tree burr, and I'm just going to lay that burr laterally on the side of the tooth, and I'm rounding all of these terminal line angles. When I do that, and I injection mold in this tooth, I'm spreading those forces throughout the tooth, and I'm not really worried about polymerization shrinkage here. And what we actually think is that polymerization shrinkage in this situation can actually help us retain that restoration on the top of the tooth. Again, GV black preparation, slot prep we talked about. And what I want to show you here is just some examples of the Clark Class 2 preparation. There are going to be videos online. There'll be training, if you want to learn more information to see this. But this is just kind of an overview of the preparations itself. We have this long radius bevel. So instead of with an amalgam restoration that we just have a box here, we're taking a radius bevel from the inside out. We're removing as little of the deadened as possible. This is the Comet burr block that we use. And these are burrs that I use every single day. We make this easy and prescriptive, like all the other steps that we showed previously, is you just write out the burr block and you have everything you need. Another example of what the preparation design looks like. This is on a typodont. We can see all internal line angles, this large radius bevel across the tooth, and our restoration, again, somewhere buccal and lingual, we're going to wind up here. Clark Class 2 preparation on a typodont tooth. I just wanted to show you some examples to see what these preparations look like. And again, these are examples of some teeth with with the Clark Class 2 preparation. So again, no sharp internal line angles. Everything really is rounded. These are non-retentive preparations. So I just wanted to take a break just for a second here, take a sip of water and see if we had Dr. Bustamante, Dr. Koenig, did we have any questions that we needed to get to, or we're doing okay so far?
No, we've had questions come in. We've been answering them as we go along. I'm not sure what happened. The poll didn't seem to work. At least I didn't see anybody voting, so I'm not sure if that was a technical difficulty on our end.
I saw it on our end.
The poll appeared, but I didn't see any votes come in.
Okay. Yeah, I'll show that afterwards if we can. Okay, so let's talk about the matrices now. So you're familiar with, with what metal matrices look like. And on first glance, this is somewhat similar, right? So we have a ring, we have a matrix, and we have a wedge. The design of these are very different. The rings themselves, so these are nickel titanium, and there's actually an inner and outer ring here. And the reason for this is we need much more separation pressure because we're not going to be burnishing the mylar whatsoever. We need more forces on these teeth. And there's 2 different rings, a molar ring and a premolar ring with primary teeth. Sometimes I use the ring, sometimes I don't. And I really mix and match these rings. Sometimes it really depends on your embrasure and size and shape on what ring that you're going to use. The diamond wedges are designed very differently than a standard wedge. One of the problems that I have with a standard plastic wedge is, and I'm sure many of you have this issue where you'll have a gap between your box and your matrix. And the way we try to solve that, the way we try to close that contact is by jamming a wedge harder, deeper into the tooth. The problem when we do that is that spine of the wedge increases, and that's where often we get these kissing contacts, is because as we push that wedge in laterally, that spine is increasing. We may have a good marginal seal, but we've completely blown the position of where we want that contact. So the matrices, these are 0.75 millimeters of mylar. They're pretty stiff. They're in multiple sizes, 4.5, 5.5, 6.5. There's some other sizes as well. And majority of the time I'm using a 5.5 matrix with primary teeth. We don't have a matrix yet. That is coming. What we use now, like in Dr. Bustamante's case, he just took, I believe, a 4.5 and he reshaped that. But hopefully sooner or later, there will be matrices specifically for primary teeth. Just wanted to show you a case. It was primary teeth. Just want to show you an example. So we have our matrix in place. We have our ring. We have our wedge. And if you notice here, unlike metal matrix, it's not slammed against the tooth. So as we place that heated composite, it's actually going to flow from the buccal lingual and 1 to 2 millimeters past our margins here. So on this side, we're going to place a Bioclear restoration. This side, this was traditional metal matrix where the restoration was placed. And then after a restoration is placed, we can see the difference. So this is where this metal matrix was placed and was burnished. And this is what happens on most of these restorations. Once I saw this photo, it really made sense to me of why was I having issues with getting proper embrasures. And this is one of the main reasons why, is you can't just push a little bit on that metal and have it burnish in one area. You're gonna wind up actually compressing that whole matrix against the tooth and it's gonna bulge out. This is just after very minor finishing and polishing of the BioFit matrix. And question is, where is our margin? So I'm gonna go back and show that one more time. This is what we get with this tooth restoration interface. Because it's enamel, this is uncut enamel that's blasted, we're able to adapt that composite all the way to the mid-facial and mid-lingual of the tooth. And this is our radiograph afterwards. And a lingual view and occlusal view. So we don't have these blocky contacts. This patient is able to keep this area clean. So injection molding. So how do we get the composite actually in the tooth? And we do that by warming composite. The first time I saw this, I actually thought that, I didn't know you could actually warm composite. I've seen some warmers before, but I had thought that we may wind up changing the properties of composite itself. We may wind up curing composite or warming it. And what really made sense to me was when I was taught is, how do they get the composite in here in the first place, right? This composite is heated in the first place to be able to get it in these carpules and into the flowable tubules. So with the Bioclear system, this is the warmer here. The composite, we turn it on in the morning and about, usually 5 minutes before we use the Filtech 1 in the carpule, we'll go ahead and put it in here. On the flowables, we usually put this in about an hour before. And then when we're done, we shut this off. That composite can be thermocycled. You could use it more than once, usually 20, 25 times, somewhere around there. So the restorative materials that we're going to use, these are all 3M restorative materials. So in the posterior, we're using Filtech 1. In the anterior, we're using Filtech Supreme. I'll show you that here in a minute. And then we have a very, so the placement protocol here is this prescriptive method. We're going to do the same thing every single time. And by doing so, that's how we get the same results at the end. And so that really makes up our injection molding process. So we're warming the composite. We have materials that we know that can be warmed, and we follow this prescriptive protocol. So, is it safe to warm composite? And what are our benefits out of this? And really, as far as the benefit is to increase that isotropic flow of the composite itself. I don't know how many of you have used warm composite before. If you haven't, the first time you use it, you've got to be careful because it comes out pretty fast. But I can't use cold composite anymore. You actually are, with warm composite, you're able to injection mold that composite. You're able to shape without having to really over instrument the composite itself, and it does not change the bond strength. It doesn't change any of those other components of those restorations. So we know it's safe. We can use these. We can heat these materials, more than once. We don't have to throw that composite out. and the speed and adaptation of placing these composites is much greater. So with the Bioclear method, we're using two different composites from 3M. So the bulk fill flowable, the way we tell that is green. These syringes were just redesigned for the flowable, and so the whole syringe is green, which makes things much easier so you don't mix things up. And at the end of this cap, where your thumb rest is, it has the shade on top. So when we place our restorations, we're placing the flowable first. I'll show you just a minute, and then the bulk fill in the paste together, and we're using 3M Scotch Bond Universal. In the anterior, again, similar on the Filtech line of composite, but this is the Filtech Supreme Ultra, and same bonding agent. So it's just a matter of green for the posterior and blue for the anterior. What I wanted to show you is just a few slides of what's the difference between layering versus injection molding. And for many years, even in dental school or even in my career, every course I went to, every speaker I went to said, we have to mitigate these forces in the tooth, and we've got to layer composite. It turned out that it was a preparation design issue and not placing the composite issue. But this is an analysis of a micro CT. So they took basically dyes and prepped these teeth and filled them. And what we can see here is that between the layering, injection, molding, there's 7 times more defects within that restoration itself. And the reason for that is every time we're putting that layer of composite, we're just incorporating more air and voids in the material itself. And so what we can see is, unfortunately, where those voids are the places we want them the least, which is at the margins. Another study using, these are just dyes, and the composite was either layered at room temperature, was injection molded, and you can very easily see where all of these voids are. Number one, this takes, using layered composite takes significantly longer, but internally you can see all the stresses that we have secondarily to these voids. Okay. So just going to summarize our steps here for our posterior composite. We're going to etch the tooth for 20 seconds, rinse and dry. We're going to place our bonding agent, which is our Scotch Bond Universal. And at this point, we're just scrubbing into the dentin. So this is immediate dentin sealing. I don't want to touch the enamel. I don't want to spread that bonding agent all over my matrix. If I do that, I'm not going to be able to go through and flow my composite later. So for 20 seconds, we're going to scrub that bonding agent into the dentin, air thin, and light cure. Then the next step that everyone's not used to, if you're not familiar with Bioclear, is we're actually going to reapply bonding agent. At this point, it's just a surfactant. So we're going to put our bonding agent in. I use typically a little bigger brush, and we're going to extend it all the way around to the enamel throughout the whole preparation. We're going to agitate slightly and dry, and then we're not going to cure whatsoever. This is literally just a surfactant. Then we take our heated flowable and we're going to inject into our preparation. And without curing, we're going to now use our Filtech 1 bulk fill and inject into that flowable. So this is very similar to like with impression compound, where we're going to use light body and heavy body, and we're going to mix those composites together. And what we're going to find is, as we injection mold into the tooth, people ask us often, well, what happens to all that bonding agent? What happens to the flowable? If you look very closely under magnification, as you injection mold that third layer, that bulk fill composite, you're going to see your bonding agent and your flowable actually spread out laterally and occlusally, and we're going to push all that material out to the periphery. So I have very little flowable and very little bonding agent that's actually left behind after injection mold, and I would probably say 85% or more of that restoration is the bulk fill material that's left. I'm not going to instrument this very much. The majority of the finishing we're going to do is with discs and with the burr. I find the more that we're manipulating that resin like we did with our layering technique, we're going to increase voids. So I want to show you a video, just kind of a summary of our steps here. So we have our matrix in place, our wedge, our ring. We've etched for 20 seconds. And dry. This is not, Carrie's still here. This is still Carrie's indicator. So this is our immediate dentin sealing. We're taking our Scotch Bond Universal and we're going to agitate in the dentin for 20 seconds. light cure, and then we start an injection molding process. So now our next step is we're going to use that bonding agent again, and we're going to spread this laterally throughout the whole tooth. So covering the enamel and dentin. This step only takes a few seconds. We're going to dry. So remember at this point, this is just a surfactant. We don't want to cure here. Then we're going to take our heated composite. So my assistant's going to hand me the flowable out of the warmer, and we're going to inject with back pressure here slowly and to spread that composite throughout the tooth. So we can see there the gingival margin, unlike a metal matrix, we're not sealed down here. Our composite's going to be flowing about, maybe 1 to 2 millimeters past that quote unquote margin. And we're going to express it both buccally and lingually. So we do this very slowly and intently to really make sure that we're not increasing, we're not getting voids. The flowable material, actually the syringes themselves were just redesigned, and the syringe itself actually has a one-way valve in the syringe, and as you depress the plunger down, the composite's coming out of the tip, and we're actually any air that's trapped in there is coming out through the plunger in the back. And I found I didn't get a lot of voids or air bubbles before, and I really don't I don't have that now. You can see our heated paste composite is same thing. We're injection molding into this area. So most of our bonding agent, most of our flowables actually come out here on the periphery. We're going to simply clean that off, and then we're going to light cure. Just one quick a point here with lights is I really implore everyone to have your curing lights checked. There's been many studies at dental schools and in private practice where they've gone through and put a light meter on your curing light. Unfortunately, some people are buying curing lights on Amazon or other places that don't sell to dentists directly. And they found is that a vast majority of these curing lights don't have the proper outputs. So something that your 3M rep will do for you at no cost, they'll come into your office. They will actually use a device where they can connect that light meter, that radiometer to a laptop, and they will test all of your lights for you and let you know if the light needs to be replaced, if you need to modify your curing times. And they'll put a sticker on that light for you. That way it's tracked. It'd be really unfortunate to place sealants or whatever restorations you do and do a beautiful job, only to find out that you're not getting proper depth of cure, you're not getting a proper light output. And again, this is no cost. They'll come do this for you. They'll come do this once a year. And I really suggest when everybody gets back, if you do nothing else, to please have your lights checked. So I wanted to see, do we need to, we're doing okay on time here. Do we have any questions that we need to stop and ask, or we're doing okay? Maybe, let's see here. I'm curious on tough pediatric cases, kicking a 6-year-old, acceptable use, global. So that's really not in our scope of discussion today. With how do you clean off the excessive, perfect. We're not going to really go into we'll go into a little bit of detail here. That's a perfect segue. Thank you very much. So what do we use to finish and polish? I never really used discs whatsoever before I started training with Bioclear, and a majority of the time I'm doing a lot of my contouring with a disc. It's very, very quick. I would say that if I'm going to do a quadrant of proximals, even on a permanent teeth, I'm probably at least 10 to 15% faster now using this method than with metal matrices. And the reason being, when you have a matrix that's shaped like a tooth, I'm not having to go through like I did with metal matrices and try to create that embrasure, have to go way under the gum line and get a bunch of flash off, have to try to, use a very thin diamond burr to recontour. Pretty much, I would say 80% and 90% or more of that final shape, the restoration is already there. The finishing here, often I'm going to do very quickly with a couple diamond burrs and a disc. So I want to take you quickly through the finishing and polishing protocol that we have, and you'll find that this is actually very fast, and the results that you get really, for me, look like this almost every single time with very little work. So we're going to use our diamond burr first. You remember from dental school, we're just making smaller and smaller scratches. So that initial shaping is going to be with our coarse diamond. I'm going to do that very quickly. I'm going to take off any flash. Occlusally, I may use a round diamond or a football diamond, and just to clean off any occlusal flash that we have. Then our next step is a disc. I used to not like working with discs, and this is, I would probably say, a vast majority of my shaping is going to be with a disc now. Once you get used to using the disc, you learn how to properly hold that disc. I find I'm not gouging like I did as much with a diamond burr. I'm able to really create nice divergence profiles. I can round line angles very easily, as with a flat or with a diamond burr, I was tending to make everything much more square. So this is really after, only a minute or two of using that coarse discs. 3M makes, I think three or four different coarseness of these discs. And with the Bioclear method, we're just using a coarse disc throughout this whole process. We're just making our scratches smaller. Then our next step is to use a magic mix. Magic mix, you can think of it as kind of like a pre-polish. This is basically 3 different grits of aluminum oxide particles in a binder. And we're going to just use a regular Profi cup. And after about 2 minutes, we're going to basically just glob this on. And in this case, it'll probably take me a minute or two. And we're going to go over kind of just like you do as you're cleaning a tooth with Profi angle. We're going to go around our line angles, and we're going to get to the point where our scratches are barely visible. And then our very next step is we're going to use the Rockstar polisher. This is a diamond impregnated cup. These are reusable. They get expensive. If you're using one per patient, you don't need to do that. I find these last a while. You can sterilize them. And at first, I'm going to run this dry. If you have an electric handpiece, it does make things a little easier. You don't have to whatsoever. I find with electrics, I really have more control over the speed. But we are going to remove those last remnants of scratches. And then with water and pressure is going to be our final polish. So this whole sequence, I'd say for the anterior, is maybe about 5 minutes. And we're not using, 3 or 4 different grits of discs. We're not using, 3 or 4 different types of cusps, of cups. This is really diamond, disc, magic mix, and the polisher. And these 4 steps, this is the type of gloss that you're going to get. And this really will stay. These feel like porcelain when you're done. And it does not take very much work. And really after a couple times practicing, those are the results you're going to get every single time. So I want to show you, Dr. Sheridan had mentioned about primary teeth. So I wanted to show you a case with primary teeth here. So one pearl of today, I don't know if people do this normally, but I'd like to, after I've went ahead and given anesthesia, is I'll go ahead and check the contacts before we put the rubber dam down. And I find that way, and often I'll take a photo, and that way that I can see where those natural contacts are. And I find my finishing and polishing is much easier afterwards, that I don't have to go back through and do a lot of occlusal adjustment, because as I place the restoration, I know where those contacts are going to be heavy to start with. So this is our first step. We're going to disclose the tooth. This actually already has a wedge in place. The first thing I'll do is place the disclosing solution after the rubber dam is placed, and then we'll rinse and use the blaster. And that's what our enamel looks like. And then we're going to place a pre-wedge here, and I'm going to use my Comet burrs. And this is our Clark Class 2 preparation. So that's cleaned and blasted enamel. Our Biofit matrix in place, and what we can already see is this is the actual shape of the tooth. So we've injection molded, and I'll use a hemostat and just really spin this matrix out. And this is after this has been Rockstar polished. This whole restoration for me now probably takes about 35 minutes, somewhere that. And again, we've grabbed our enamel. We're out here on the periphery, somewhere on the buccal and somewhere on the lingual, and just minimal finishing and polishing when we're done. So what we want to do now is move over to Dr. Koenig, since he's actually going to do a live demo for us. Can we switch over to you, Dr. Mark?
Yep, sorry, I was just answering some questions.
So
Yeah,
I'm gonna let you take over.
Okay, here we go. I hope. Host disabled participant screen sharing. So you've got to let me share the screen, Dr. Solomon. There we go. Well, still says I can't share because you've disabled my screen sharing. And you're on mute right now. There we go. Okay, I hope everybody can see my screen. Dr. Solomon, you want to go off mute so I can hear your... There we go. So are you seeing the model now?
Not yet.
Not yet. Okay, let's see. Sorry, everybody. Share.
There we go.
Okay, so here is a model. We're going to do the class 2 on the distal of tooth number 3. So, you know, we have Dr. Clark, class 2 preparations, both on the distal of number 3 and the mesial number 3. We're going to focus on the distal of number 3. I have a Bioclear Biofit matrix here. And we're going to come in and we're just going to slide this matrix between the teeth.
Prior to this, I just want to make one quick suggestion. If you're not in the habit of disking or adjusting your adjacent contacts, no matter what type of matrix you're using, it's something that I do routinely, especially if you've had a pinpoint contact or you weren't happy with the restoration that was placed on the adjacent tooth. I'll go back in, I'll just round out that contact of the adjacent tooth to really match the same roundness and height of the restoration that I'm in place.
Yeah, that's an important point, that contacts have to function as a pair. So if the neighboring tooth has a very non-ideal or a very funky contact, you're not going to get an ideal contact. So idealize the contact of the neighboring tooth. Okay, so I have the matrix in place. I'm going to firmly seat the matrix. I'm going to kind of massage it down. And then I like to come back and have you inspect your work. And let's see if I can keep this in focus here. And you can see I've got the matrix. It's seated fully all the way down to the gingival margin, both on the buccal as well as here on the lingual. Next, we have the diamond wedge. You could insert it either from the palatal or from the buccal. The general rule of thumb is that you want to insert the wedge from the side with the more open embrasure. And I want you to notice how the wedge is not just a flat wedge. It's kind of shaped like a suture needle. So when we come in, we're going to dive it under and through the contact, more like we're suturing than we're just kind of pushing it straight through. So while I insert the wedge, in order for the wedge not to displace the matrix, I have to hold the matrix down with heavy finger pressure. And here we are. I'm coming under the contact and I've got the wedge seated. And once we're seated, we can turn the cotton pliers around and give the matrix a firm push, a firm seat. Now I want to come back and re-inspect and make sure I haven't distorted the matrix while putting in the wedge. So I still have the matrix fully seated on the buccal as well as here on the lingual.
Dr. Koenigs, I wanted to just make one point I probably didn't make very clear earlier, is that, you know, what we try to do is progressive wedging. So when I am preparing the tooth and I'm going to place an initial wedge, I'll use a wedge one size smaller than typically that I'm going to injection mold. So if I'm going to start with, like in this case, if there's a large wedge, I may have used a medium wedge to start, prepare the tooth, remove that wedge, and then when injection mold, I'm going to go up to the next size wedge. With primary teeth, when we use this, the doctor was asking about, placing these restorations with primary teeth. We're going to do everything exactly the same. So I may use a small wedge to start. Sometimes we'll find with primary teeth is because the embrasures are more wide than permanent teeth, sometimes I'll actually wind up using a large or an extra large wedge as the next step right before re-injection mold.
Okay, now I'm ready to place the ring, and I'll just kind of bring the ring in view here. And one thing I want you to notice is that when the feet of the ring are parallel to the occlusal plane, the ring itself is angled upwards somewhere around 15 or 20 degrees. And this is so that you can clear a rubber dam clamp. Bioclear certainly recommends rubber dam if at all possible. The ring could go on either to the mesial or to the distal. You can spin it around. In general, we would recommend that you put the ring onto the distal. It gives you better visual access to your preparation. Okay, so let me come in here. Kind of drop it in, come down the occlusal plane, and drop the ring in. And then give it a firm apical seat. Okay, now we want to come back and re-inspect again that our matrix hasn't gotten distorted. So you can see the matrix is here, down at the gingival margin, both on the lingual, and let's see if I can get this to refocus here, as well as here it is on the buccal. Okay. Okay, now one of the things special tools, we're going to do bulk injection molding. With most composites, most layering composites, you're limited to a depth of cure of about 2 millimeters. With the bulk fill materials, depending on the cavity type, we can go either 4 millimeters in a class 1 or 5 millimeters in a class 2. So this is the go, no-go probe. And the top of the green band here is 4 millimeters. So I can measure a 4 millimeter depth of cure in a class 1. The top of the yellow band is 5 millimeters. So now I have my matrix in place. I can measure my cavity depth. And what I can see is that the top of the yellow band is right about where the top of the marginal ridge is going to be, or even a little past the top of the marginal ridge. That means I'm within 5 millimeters and I can bulk injection mold this. If we had a very deep cavity preparation, it was 6 or even 7 millimeters, we would have to go to some kind of a margin elevation or some kind of layering technique.
And I'll tell you, I rarely use that, because most of the time we're treating virgin teeth, and
Right.
I'm rarely ever anywhere close to past 5 millimeters.
Right. This is the push-pull instrument. So again, we want to make sure we've idealized our contact. We can take the push-pull, we can drop it into the cavity preparation, and just walk it over up against the neighboring tooth. And then what you do want to do is with your mirror, look through your contact to make sure you have a really solid contact. In my case, it looks like my contacts may be just a little bit on the light side. I'm not totally happy with that contact. So there's an optional technique we're going to show. Now, one of the things is I'm working here in my basement office. And in my basement office, I don't have water, I don't have suction, so I'm going to skip the acid etching steps. I'm also going to skip the bonding step here. And that way I can continue to reuse this tooth. But I also, since I'm going to be using light cure materials, I have to put my little orange filter or I will start curing my composite before I want it to. So I have to kind of rig this up. I got a little rubber band here on my camera, and I can put a curing light filter. Then I have to get everything back in focus. Okay, I'm going to show a little trick for idealizing, excuse me, for getting a tough contact. So here I am with the flowable. In this case, for posterior, Bioclear uses the 3M Filtech. I know it's a little out of focus. Bulk fill flowable restorative. This is also a high depth of cure, low shrink flowable material. Cures up to 4mm depth of cure. I'm going to take a little bead of flowable at the corners, inside, over, and outside the matrix. Inside, over, and outside the matrix. And now I can come in with my push-pull instrument. I can walk the matrix against the neighboring tooth, and I can come in and tack cure. So now I've kind of spot welded this matrix in place against the neighboring tooth if I have a tough to get contact. That's an optional technique. You'll have to evaluate your matrix and your contact. Now I can kind of come and look through the contact here, and I can see I think I'm a little happier with that contact.
So just for reference, I rarely, sorry to interrupt, I rarely have to do this because there's 8 pounds of separation force, and we have young teeth with thick PDLs. I maybe 10% of the time, I'm doing this additional step.
So now we're going to assume that I've acid etched, rinsed, and dried. I'm going to assume I've done the bonding protocol, which for the Scotch Bond Universal, if you're using that as you agitate the dent and get everything wet for 20 seconds, air thin and light cure. So we've light cured the adhesive. Now we're going to put a second coat of adhesive on and air thin it. I'm skipping that step here. Now we're going to come in with the flowable. One thing you may have noticed from the video is how I'm pushing the matrix off the tooth here, and now I'm starting to inject with very light finger pressure. And if you watch, you can actually, if you're looking toward the middle of the top of the screen, you can see the flowable creeping around the corner. And again, I'm extruding very slowly here. I want to give this flowable time to flow.
This is why it's important to, if you're going to do this, to use the whole system. We'll get asked all the time, well, can I use a glass ionomer, or I don't have a heater, can I use my regular composite? This really is designed as a system. And so if this is something you're going to do, I encourage you to just do all of the steps. All of us, sometimes we try to reinvent our own restorations. If you really follow this prescriptive method, I can guarantee you results you're going to get every single time. We know that this composite has been studied copiously, that it doesn't change the properties while heating, and that trying to do a GI or another material that doesn't have that thixotropic flow, we're just not going to get the same results.
Right. Yep. And there were some questions. Can I skip the flowable, for example, and can I use a GI? And what we'd say is all of these steps have been validated with 3M materials and the Bioclear method. And if you start skipping steps, then we can't really promise you're going to get the kind of results we see. So here is the 3M Filtech 1. This is, again, a high depth of cure, low shrink restorative material. I'm going to clear the little bit of air gap and make sure I have composite flowing out the syringe, out the tip, before I inject. If I have that air column in the tip of the compule, I'm going to start injecting air into my flowable. Now I'm going to drop it right down to the floor of the prep, and I'm going to start injecting molding. Again, I'm going very slowly here.
And the key here is to injection mold into that flowable. If you try this without flowable, you're going to wind up getting voids. It just happens every time, and or most times, and that's why the method is what it is. But you don't want to start injection molding really until you bury the tip of that paste composite into the flowable, so you don't get air bubbles.
So I'm continuously injecting. I can feel the stiffer material, and I let it push my capsule tip up. I'm still injecting, and I'm going to pinch it off on a cusp tip. Then I have a paddle instrument here, and I can clear away a little of the excess flowable and kind of form the central groove, I got some flowable here I can wipe off. Come in on the buccal. Again, I'm just kind of massaging it against the tooth. And basically that's all I'm going to do. I'm going to cure this. And then Dr. Solomon talked briefly about the finishing sequence with burrs and discs and magic mix. So I'm coming in here. The curing protocol for a class 2 with these high depth of cure, low shrink materials, you cure 10 seconds from the occlusal. Now I can take my filter off. I can take the separator off. I'm going to come in and cure 10 seconds from the buccal. Interproximal curing. This is really only possible with a clear mylar matrix. If you have a metal matrix, you can't cure through the metal matrix. So we're counting on the fact that we can cure the interproximal through a clear matrix. So I've done my light curing. I come and I can take the wedge out. Come on.
So one doctor asked about an overhang. So what you're going to see here is that as soon as we take this off and we do just a little bit of finishing on the occlusal, there won't be around the periphery of preparation. You're not going to have overhangs whatsoever. Right now, it looks like there's a lot of composite on the tooth. The anteriors are even worse. If you remember back to the beginning, I showed you, one case that was injection molded on that lateral, and there's a lot of composite afterwards. But this step really in about 5 seconds, it looks like, this big tuft of composite over the top, but underneath here, it is all that smooth injection molded mylar finish of the composite. And so once Dr. Konings takes off the tooth, we're not going to go through and do the finishing steps here, but there are lots of videos online to show you. Once we clean off that excess, what you're going to see underneath is that smooth margins. And when he pulls this burr out, then you're going to see what, pulls the typing tooth out, you can actually see underneath what your contours look like.
Yep. So let's do that. Come in here. I can unscrew this tooth. And Dr. Solomon, do you find assembling the matrix, the wedge, the ring, in the beginning, maybe it took you a few tries and now you can pretty much assemble it pretty easily?
I'm faster now with this method than I am with a standard metal matrix. So you can see here, so there's an extra composite over the top. That's going to come off, very easily here with your disc or your burr. But what we wanted to show you is what your quote unquote margins are afterwards. Now, again, we don't have a margin here, right? This is a tooth restoration interface. The TRI, your composite extends somewhere on the buccal, somewhere in the lingual. And if you look here, most importantly, proximally, there's no quote unquote flash. When you have a matrix that is designed with an actual shape of the tooth and the way that the diamond wedge is shaped and using heated materials, those are the contours that you're going to get every single time. If anything, I may pass, I may take a finishing strip and run it through here just a little bit. But if you do all the steps properly, these are the results you're going to get every single time. So you see the sprue, a little bit of excess composite there on the occlusal, that comes off easily. But that's what your margins are going to look like.
Yeah, and this was just from my little tack curing it in place. So yeah, you have a little bit of finishing here. You can do this with that football carbide and a soft flex disc. That's what you have. And you can see how the contact is just slightly, there's a slight concavity in the middle of the contact. And that's actually normal. That's what we want. That's how you get this broad contact. So this outer rim is all the places that this restoration is contacting the neighboring tooth. That's how you get a really broad contact.
Someone asked about back-to-back restorations, and one procedure that I do very often is I'll do a direct mesial or direct distal on the adjacent tooth, where we're just removing the caries and slightly beveling. And in that instance, I'm using just flowable. And the back-to-back restoration, as far as speed-wise, is much, much greater. We're saving a lot of tooth structure, and the steps are pretty much the same, where I'll do that direct, in this case, a direct mesial. I'll remove the caries down to, slightly to the dentin, bevel, put my matrix in, and same steps, except I won't use the paste composite. I'll just use flowable, do a little bit of finishing, and then use the matrix and restore the adjacent tooth. If you're doing back-to-back restorations, you're doing 2 full, Clark Class 2 preparations. Same thing like I do with metal matrices is I will use I will restore one tooth, remove the matrix, and then restore the other.
So there's a couple questions. What do you do if there's bleeding? Astringent, basically ferric sulfate.
And one doctor had asked if we're using Isolite instead of rubber dam, is that okay? I try to use rubber dam most of the time, but I do use Isolite. And one thing you may want to do is either use liquid dam or astringent. I'll often put, if I'm just using the blaster to clean a surface, I'll either use a liquid dam or the astringent on ahead of time, and place that, either light cure it or let it sit for a minute, and then go ahead and blast. And I find a very little bit bleeding later.
Yeah, so another question, how are you not getting an overhang? So the matrix, which is really an anatomic tooth form, it's not really a matrix. A matrix is designed to contain material within a preparation. We don't want to contain the material in the preparation. So the matrix goes past the subgingival margin, and then the wedge and the rubber dam seals the matrix against the tooth. That's how you don't get an overhang with this technique. It says you want a concave contact. Well, think about 2 round objects coming together. Think about 2 bowling balls or 2 billiard balls coming together. You would have a point contact. The way to get 2 round objects to have a really broad contact is to have a slight concavity in the middle of the contact. That's different than having a kind of a reverse contact where one tooth is wrapping around the neighboring tooth. And blue in the anterior, green in the posterior. Yeah, so blue Filtech Supreme and Filtech Supreme Ultra resins in the anterior, and then the green Filtech 1 and Filtech Bulk Flowable in the posterior.
So as far as the blaster goes, when if I'm blasting a tooth, I'm going to blast the entire tooth. I'm going to clean as much of that tooth off as possible prior to my preparation. And then right before I restore, I'll often take the blaster, maybe just for like 10 seconds, just to clean out the preparation in the periphery once again. Sometimes it's dependent on the behavior too. If my patient's having a tough time, I may not do that, but most of the time I'll go back in with the blaster. Do you notice any bleeding between switching wedges? Yeah, there's always going to be some bleeding, but using that first wedge just as separation and to push the proximal gingiva down. That's one big problem that I see when people don't pre-wedge, is that gingiva, that coal space, is especially if hygiene isn't very good, you may have gingivitis. You've got this big hyperplastic piece of gingiva, and when you try to prep, often you can't see caries or that aprismatic enamel that's way down deep, underneath that margin of that tissue. Also, sometimes what I'll do is when I place that the pre-wedge, sometimes I'll take a flat piece of metal, a stainless steel, like you'd use just as a sectional matrix, and then I'll place that in there as well, just to protect the adjacent tooth.
Okay, there we can see the contact. So it's about in the middle of the tooth. It's tall, occlusal gingivally, and it's broad buccolingually. And again, since the distal tooth number 2 is rounded, I have to have a slight concavity in the middle of the contact to get that broad contact.
One of the doctors had asked about primary teeth. That's so showing, having preparation models and photos. That's something we're working on right now. One of the, again, silver linings of this pandemic is I've been able to spend a lot of time just working on Bioclear, and Dr. Clark and I have spent quite a bit of time on the microscope and drawing out designs. I would say as far as the prep goes, I'm preparing the teeth similar, very similar to how I do for permanent teeth. And one of the advantages there is because we're not actually going deep into the tooth and we're trying to grab as much enamel as possible, I find it less of a chance of nicking a pulp horn with these preparations. I will slightly flatten out cusps as well. In order, I may shoe one or two cusps of the primary tooth because it's, because the tooth is small, but sooner than later, we're going to put out some designs, some drawings and photos of primary teeth, but the preparation is very similar. If you saw Dr. Bustamante's preparation that we showed previously, not much different than permanent teeth.
We worried about the aerosol produced from the blasting. Well, we wouldn't have worried about it about 2 months ago.
Right.
I think there's a lot of questions around aerosols and stuff that, in general, I mean, certainly the aerosols produced during high speed, any high speed procedures are, I can't answer that right now. I'm sure we're all concerned though.
So, so doctors had asked about courses. So let's go ahead. Dr. Konings, I am going to take over.
Yep.
Hi, everybody. Okay. So we're getting close to wrapping this up, but what I did want to do for everyone is, okay. All right, so if you have questions, I know we could only get to so many of you today. Here's my email address. Of course, like all of you, I'm at home, so I'm very reachable right now. My main email address just for Bioclear to make sure I don't miss any of your emails. If you have questions, you want me to call you, just shoot me your phone number. I'm happy to discuss all this stuff with you. Again, I said, I don't make any money off this. I don't sell, matrices and I get a cut of it. I'm just very passionate about this and I'm willing to help anybody out there if you have questions, even, 3 months from now, if you have questions, if you buy all this stuff, you take a course, you have questions, especially in the anterior gets to be a little bit more technical, picking matrices and talking about tooth shapes and emergence profiles. That was done for me. I send in pre-op photos and one of the experienced Bioclear doctors would go through with me and talk about which matrices and steps and preparations. Dr. Koning's email address is here at 3M. Basically he is their Bioclear guy, and if there's a question that he doesn't know the answer to, I don't think I've stumped him yet. If not, he will direct you to the right person. If you have questions about the materials themselves, especially about bonding, specifics there, feel free reach Dr. Konings or myself. I also wanted to include Tanya. So Tanya is she's in charge of the Learning Center. And so if you have questions about courses, her email is here. And so if you want to learn more, if you want to see more videos, this was just put out, and this is one of the best Bioclear videos that I've seen. And I really recommend, if this is something you're interested in, go on YouTube and just put in Bioclear in Seattle. Dr. David Clark, the founder of Bioclear, and then Dr. Richard Young, who's bonding expert and I think one of the best dental photographers in the world. They go through and kind of go over some steps like we did today, but they'll also show some more information, some bigger cases. And then lots of other resources for you. So Bioclear, their website is here, bioclearmatrix.com. There's videos, you can purchase all the products. It has a list of all the courses. The courses I showed you at the beginning has all of those courses. Of course, some of the courses have been canceled, but things are getting rescheduled. And in order to help everyone that was supposed to go to one of the hands-on courses, I was supposed to teach ones, 3 or 4 this year. Of course, many of those have been canceled. So what they're doing instead is a virtual hands-on course. It's actually, they've had a couple of them and it's really, I didn't know how it's going to work out, but it works out great. what you'll do is Bioclear will ship you everything. So all the stuff you saw today, the warmer, the composites, everything that you saw, they will ship that out to you. And then it'll be a learning session, small class size. I believe it's 5 to 1 or 6 to 1, and to really do that same hands-on course that we normally do at a hotel or some other facility, and it's all with with Zoom, and you really get I think really good hands-on experience. We send photos back and forth through cell phones, and the feedback so far has really been good. The list, someone had asked about live courses. So as I said, some of them, of course, have been canceled, but they're rescheduling, and there's more again this year. They're all over the country. I think last year we did, I don't know how many of them, I think at least 30. And they're really all over, both sides of the coast. And that course is going to go over posterior, and it's also going to go over black triangles. I know for us in pediatrics, black triangles is not something that we treat very often, but the steps to restore black triangle and for any other anterior, all the steps are all the same. It's just a matter of what matrices that you use. Same thing with peg laterals, with class 4s. The steps are all the same. Today was really supposed to be a high level overview of everything. I don't expect you to be proficient in any of the stuff, but at least you've seen, all of the steps, and it's just a matter of adapting those steps to what tooth that you're working on. Again, Tanya's email address is here. So if you have questions about courses, don't email Dr. Konings and I. We may not have all the information for you, but Tanya will be able to get back to you and give you all of that information. And then Bioclear this morning actually gave this to me. So they put together a deal, which is, I think, really reasonable. We're doing one hands-on course in August. We were going to maybe do ones next month. It's all dependent, like all of you, we don't know when we're going back to practice. And I wanted to do some in May, but I didn't want to volunteer to do them, and then we're winding up back. So if we find out, at least in California, if I find out that, we're not going to be back until June, I'm definitely going to do some hands-on courses, very similar to, set up here, except, I'll be at my office, we'll have typodonts out, we're going to go through all this stuff in detail. And $495 is actually, I think, a really reasonable deal. And then they're going to give you, a whole mini anterior kit that you have. And then Dr. Bustamante and I are going to be teaching the second annual Pedo hands-on course. So that's actually at the Learning Center, 2 days, very intensive of posterior and anterior. And by the end of that course, you should feel pretty confident in placing single restorations or multiple back-to-back restorations in the posterior, doing cuspal coverage like we showed some cases today. And the anterior, we'll discuss class 3s, large class 3s, class 4 restorations, peg laterals, and two-size discrepancy. It's 2 very, very full days. We feed you, the hotel we stay at is beautiful, and the Learning Center really is, as hands-on as it gets. It's a little tiring after those 2 days, but you're definitely going to get your money's worth, and you'll be very proficient by the time you finish those courses. And then also, if you do, she put a discount on the Learning Center. So again, if you have any questions at all, please go ahead and email Tanya. If you're interested in doing one of the virtual hands-on courses, go ahead and send Tanya an email. And if we can schedule courses next month and I'm not back to practice, then we'll definitely, I've got all the setup to do it. It's just a matter of, if we're all going to be working or not. Okay, so I wanted to, this presentation recorded so I can watch for review. Yes, we definitely did record it. I have to figure out how to get it out to everybody, but we'll definitely do that. I may post that on IPEDO, or we'll have it on YouTube, but we'll definitely make it available for everyone. So I just wanted to thank everyone today. I'm really glad that all of you came and joined us. This is, I mentioned from the beginning, this is really something that I wanted to do for years and just had the opportunity to. Hopefully next time I get to do this is face-to-face and I'm not just here staring at a camera, which is still very weird. And so I just want to thank you for your time. Please reach out to us if you get, and we're here for you. Dr. Konings, Dr. Bustamante, did you want to say anything?
Thank you very much.
Thank you. Yeah, and I will get the video from Dr. Solomon. He may publish it some places, and I'll make sure I get it up on YouTube. So just search Bioclear Method Pediatric Lecture. We'll get it out.
All right. Thank you, everyone. Stay safe, stay healthy, and we'll talk to you soon. Have a good afternoon. Take care.
Thanks, everyone.